Hello, thank you for attending this session today. I am K.Williams Luby, and I am an affiliate of M.T.P.W. I'll be providing a short overview of data-driven approaches to advancing research and patient care in pediatric oncology, with the context of the importance of structured radiology data. Just a brief overview of this session. I will be focusing on pediatric oncology. And when we think about childhood cancers, the terms rare, uncommon, and frequent are commonly used to describe the occurrence of cancer in children. From a prevalence perspective, only around 400,000 children worldwide are diagnosed with cancer each year. And there are myriad subtypes, some of which are so rare that there are less than 300 cases a year observed. But rare does not mean that our attention and our investment is not warranted. And there has been tremendous and substantial improvements in childhood cancer outcomes. The current survival rate for childhood cancer, and I will qualify this as being a United States statistic, is close to 80%. And this is a vast improvement compared to only around 50% in the mid-1970s. However, these rates are misleading. There are many types of childhood cancer with far lower survival rates, for example, ATRT, DIPG, as well as high-risk neuroblastoma. And furthermore, survival does not always equate to cure. Survival rates are based on 5-year survival, do not always account for relapse. And then added to this, the majority of drugs that we use to treat children with cancer are decades old. And if these drugs led to high survival rates and were free from long-lasting side effects, this would be acceptable, but this is not the case, and this is why we need research. Compounding this, access to treatment is riddled with challenges and its own difficult decisions. There are geographical, financial, socioeconomic, and access barriers to treatment. This is a worldwide issue. And while we know that data is important for cancer research in general, it is even more important in childhood cancers because the data we have is relatively sparse, especially in certain pediatric tumor types. So there's substantial progress on this front already, namely childhood cancer registries. We have the ability to collect vast amounts of data. We are collecting vast amounts of data, but much of this is being left behind or unacknowledged. So we have to also consider if the data we're collecting is flowing away from the patient without real-time benefit to the patient at the point of time in care, and that is what I will present today. The importance of radiology data in particular in contributing to the advancement of childhood cancer research and outcomes. So in this session, I'll provide a brief overview of what we do to support this effort with the so-called radiologist toolkit for advancing childhood cancer research with exemplary cases in hepatoblastoma as well as low-grade glioma. Just a bit about my background. I am a clinical trialist. Nearly my entire career, almost 25 years now, has been in clinical research and medical imaging. I've primarily worked in oncology, but both adult and pediatric indications. For disclosures, I am an employee and affiliate of M.T.P.W, and I will be demonstrating some of the work we do at MINT in this session. So, contributing to the advancement of pediatric cancer research. The most important thing I want to note today is that the role of radiology is essential. It's so essential. Imaging is a cornerstone of care. Your radiological evaluations are one of the most critical aspects across all touch points of patient treatment. And this extends from screening and initial diagnosis, staging, as well as response to treatment, contributions in clinical trials with image-based endpoints and research. And the advances that we've seen in the treatment of childhood cancer over the last decade have greatly improved long-term survival. We know this. It now exceeds over 80% in some cancer subtypes, but there's still work to do, and namely in understanding long-term side effects of treatment, these late effects of treatment such as cardiac, CNS, secondary malignancies, and imaging data is critical to each of these in bringing together both the clinical care and research data to improve prevention, treatment, quality of life, and long-term survivorship for childhood cancers. So most importantly to this is that it does not only apply to pediatric cancer, this is relevant to other indications as well. Challenges. There are multiple challenges that we have to overcome. Namely, the number one challenge is that childhood cancer is rare. This is the term we use. That means data is sparse. This is confounded by the fact that diagnosis is often difficult and delayed because many of the symptoms mimic common childhood illnesses, amongst other reasons. Adding to this, the criteria for staging vary by diagnosis, and while these have evolved over time as well, they also vary guideline to guideline, depending on the group publishing them. We know the importance of registries, especially in rare indications, but we also have to recognize that the reporting of information from imaging varies. The key to meaningful data and registry data, for that matter, is consistency and standardization. And information does not always make its way to registries for research. There's a significant amount of information on diagnosis, treatment, and outcomes that's stored at the institution where the child is treated. So often we have data siloing as another barrier. And all of this together is what's creating bottlenecks and making advancements. There are pressures, there's further pressure on this front, and rightly so, by patients and families who have expectations for care, for which the term rare does not offer any consolation. And lastly, and I think we just have to acknowledge this, that in comparison to adult indications, the funding for research and pharmaceutical industry investment, even in childhood cancers, is frankly underwhelming. But there are opportunities for solutions, and I believe that imaging and radiology has a critical role in overcoming this. So what are some of the research needs that imaging evaluations can contribute to? And this is not only for research, this is the information that's fueling registries as well. Imaging evaluations, screening for cancer predisposition syndrome, radiation dose selection, standardization of imaging protocols, optimizing the modalities series for best measurement and interpretation. There's a great deal to be done there. Discern the best method for measurement, diameters versus volumes, and then correlating these to overall survival and predicting outcomes. From the reporting's front, automated measurements. Should we be doing this? Is there risk? What are the benefits of this? We need reporting algorithms for staging and response to continue to evolve as we acquire more research data and information. These are the structured reporting guidelines. And then there's considerations for the oncologist as well. What does the oncologist expect as the treating physician from a report, from a radiology report? Are we meeting their needs? Is there something that we could enhance within the radiology report? And I think this last part is very important, the patient and family-facing reports. Particularly in childhood cancer, it is often the families, the parents that are the curators of their child's health record, as well as the advocates. And these radiology reports become a very integral part of managing that care. On the disease classification front, radiomics, I think, is top of the list. There is extensive amount of research still to be done and continuing forward on this front in radiomics, but this has to be connected to clinical biomarkers and in turn related to predicting survival and outcomes. Treatment response, very patient specific. And when you have a rare indication, it is very often the case that each patient case is even further unique. Dose and toxicities, resistance and relapse, understanding why drugs fail. Drug development for future therapies have in the same great overall survival and outcomes, but have a better toxicity profile. Drug delivery mechanisms, convection-enhanced drug delivery, for example, and drug repurposing. Each of these are areas that imaging data is mandatory to further research. We need imaging data. This is essential. So how are these research needs fueled? Data, specifically radiology data. A data-driven radiology toolkit might include, for example, evaluations of two-dimensional diameters versus volumetrics. Volumes tell a different story, but we have been using diameters as a surrogate for extraordinarily long periods of time because the technology was not advanced enough to let us do volumes easily. This is no longer the case. Then there is radiomics as well as tumor growth rate dynamics. But these are more meaningful if we can collect and report them in longitudinally connected interoperable image data sets, and then further correlate these with clinical data of pertinence. We still have the challenge that childhood cancer is rare and data is sparse, but there's middle ground, I believe, and that's structured, standardized data that lets us investigate more with what we already have and interrogating more on the image data that we already have available. In other words, we can still do more right now with what we have, and that we should not allow the sparseness of data to necessarily be a rate limiter. And this is what we support with our goals at Mint. That's my role. Imaging data in a connected, mobile, comprehensive, and mineable format that allows for real-time data analytics, in-depth investigation, and it's built for purpose for AI and machine learning specifically. So just to give some further background on this, Mint Lesion is a software platform in which mineable data are obtained in a semantic data model. It's HIPAA and CFR Part 11 ready to support medical research, but also a cleared medical device. This has pre-built configurable read templates with automated result reporting for screening and staging, as well as response to therapy, specifically clinical trial response-based guidelines such as RECIST, Lugano, the RAPNO working group guidelines for pediatric brain tumors, as well as all other standard guidelines. These are directly accessible within the software. And furthermore, the data are exportable in various human and machine readable formats to the point of data liquidity. CSV for external analysis, and then all imaged annotations as well can be exchanged in open formats such as NERD, NIfTY files, as well as DICOM compliant annotations. Interfacing with other systems is also possible, HL7, FHIR, as well as EHR. There is furthermore this possibility that Mint enables, which is cloud-based data collection and real-time analysis, and that's the framework of registries as well as individual case collaborations. The acquisition and annotations, including radiological findings and radiomics, are performed directly on the primary imaging data, and this, together with information from the patient history, clinical information, are all connected and exportable. This is supported again by this concept of assisted data capture and reporting with guideline-based rules, the guidelines of staging screening, the response to therapy, with conformity checks guiding the assessment. Thus, this Mint Lesion is a software for clinical routine patient care as well as clinical research, and it's designed to support and sustain a standardized approach in this generation of imaging data in the highest quality possible. So I have two exemplary use cases. One is in pediatric hepatoblastoma for staging, another in pediatric low-grade glioma using response to therapy that we'll go over. And I'll demonstrate how, despite different data sources, the approach we take with Mint guarantees uniform, homogeneous data criteria are applied to the data extraction, and this structured data is what can be universally shared and analyzed. We know inherently that multi-center cooperation is essential to generating these sufficiently large databases with consistently high data quality. This is just crucial for modern data mining. But with both of these examples, I'll show how individual study centers can conduct structured reads on already available images, extract a wide range of image-based parameters, including radiomics, associate them to these other clinical data aspects, and then transfer the resulting structured anonymized data for collaboration and data pooling. Before I go into these two evaluation cases, a short overview on a study in the UK on using pro forma reporting, standardized structured reporting and staging evaluations. The premise of this study was that detailed assessments, a prognostic stage by radiology, is a crucial determinant of how this initial therapeutic strategy offered to patients, but pre-therapeutic stage by imaging is known to be inconsistently documented. So this study also reported that despite the importance of preoperative radiology assessment, very few prospective audits of imaging reports for cancer have actually been performed, but all that have shown significant deficiency in documented staging information. So for this study, the study objectives were testing whether the completeness of cancer staging radiology reports could be improved through a nationally introduced pilot pro forma-based assessment, 21 centers in the UK, over 1,200 cancer staging radiology reports were submitted against 6 different cancer types. Radiology staging was evaluated both before and after the implementation of this reporting, and then the report completeness was assessed using scoring forms listing the presence or absence of predetermined key staging data. What they found was that 15 of these centers implemented this. In the pro forma group, only 48%, almost 49% of key staging items were present, compared to over 87% in the post pro forma group. That's a 78% improvement in staging completeness. And the majority of participants actually found that this improved the overall reporting quality in their clinical practice. So the takeaways are the clear documentation of imaging-derived staging is required. radiologists to facilitate multidisciplinary team-based decisions. The implementation of pro forma reporting does, in fact, result in a significant improvement in the completeness of cancer staging reports because it enables a subjective comparison of patient outcomes across centers and provides an auditable quality standard for cancer care. So, starting with the first use case, we'll look at pediatric hepatoblastoma and the PRETEXT guidelines for staging. Hepatoblastoma is the most common pediatric primary liver malignancy, making up 2% of all pediatric cancers. It has an incidence of about 1.76 per million, 5-year overall survival of almost 77%. And there is a correlated risk actually associated to hepatoblastoma in children, and that is premature birth. And this incidence is increasing. So the 2017 guidelines are pre-treatment extent of tumor system. And looking at the reporting, just to briefly give you a summary introduction to this, there's an evaluation and reporting of primary tumor and metastases, including liver as the primary site, lymph node, lungs, and peritoneal nodules for all present hepatic vein branches and the intrahepatic inferior vena cava, tumor obliteration, venous encasement, tumor thrombus are prompted assessments in the evaluation. For portal veins, it is the same, as well as cavernous transformation that's also prompted, and then extrahepatic involvement prompts are provided to assess if the tumor exceeds organ boundaries and the extent of tumor surrounded by normal tissue, as well as the presence of peritoneal nodules. There are derived annotation factors, the hepatic vein involvement, portal vein involvement, focality, extrahepatic disease, tumor rupture, caudate lobe involvement, lymph node, and distant metastases. These are automatically evaluated by mint lesion. The reasoning for the derivation is displayed as an explanation within the context menu, and the user can still answer the questions manually, however, without making a detailed assessment or even override the provided automatic evaluation as needed, as long as an explanatory justification comment is provided. So looking directly at how the actual evaluation looks, the evaluation of the primary tumor and metastases, additional information such as AFP level is able to be entered, vessel anatomy, hepatic veins, portal veins, extrahepatic disease, and then the derived annotation assessments shown at the top here for each of those categories based on the input data. Hepatic vein, portal vein, through lymph node and distant metastases are automatically derived based on the user entered feedback. For each location or site that's measured, prompts are given to select the location as well as a sublocation. And for each measurement, whether it's a long axis diameter or only a short axis and long axis perpendicular, even volume, further information is shown, including volumetrics in this example and the extent. There is a comprehensive report on all measured and assessed information. This is exportable information. Reporting in PRETEXT is assisted by these conformity check guardrails that are based on the guidelines themselves. And while the information is again exportable, a structured radiology report is also produced with each assessment, and restaging can be directly correlated to the prior for a comprehensive report over time. This radiology report also includes lesion snapshots of the findings evaluated directly embedded within the report. In our next exemplary case, now switching from staging to response, looking at pediatric low-grade glioma for response to therapy. This is modeled by the RAPNO working group guidelines for pediatric low-grade glioma from 2020. Low-grade glioma represents about 30% of all childhood brain tumors. It's the most common. It has a 10-year overall survival of about more than 90% with complete resection, but this is a very broadly categorized tumor type. There have been significant advances that offer novel therapies for inoperable or progressive pediatric low-grade glioma, and these have the potential for tumor control with the benefit of reduced toxicities, but there's still work to be done in terms of the late effects of these therapies, as well as improved radiation approaches and drug delivery methods. The guidelines and the way that this is structured in the assessment is that many low-grade glioma cases present with a single measurable primary tumor, but this evaluation allows for cases with multifocal lesions as well as non-measurable disease. Measurable lesions can either be defined as either bidimensional or tridimensional measurable, so long axis and short axis, or even a volumetric. and a third perpendicular diameter can either be directly measured or derived as a Z extent from a volumetric. These are typically assessed on T2 flare. Correlating clinical parameters can also be evaluated, including clinical status, corticosteroids, visual acuity. And the compartment responses for target, non-target, and new lesions and the response categories are derived based on the evaluated assessments, and an overall visit time point response is also derived. It's possible to also do additional values, so two-dimensional and volumetric changes can be captured concurrently. Radiomics features in accordance with the Image Biomarker Standardization Initiative were also derived for all disease findings. Looking at the report evaluation, you can see measurable disease and corresponding calculations and individual lesions, sums and volumes within here. Correlating clinical information parameters can be captured and evaluated, and these compartment responses for target, non-target, new lesions, as well as the derived time point response. Individual lesion trajectories over time can be visualized as well for both the diameters and volume-based measurements. In the reporting according to the RAPRO guidelines, this is the comprehensive longitudinal evaluation. The radiology report includes all measured values linked to the context, again with embedded snapshots of disease findings are provided within here. To conclude with offered solutions, pediatric oncology is a rapidly evolving area where imaging technology has accelerated many of these advances in care, but there is still work to do. A primary limitation is that data is sparse, reporting is heterogeneous, and it's often very siloed. We still need significant amount of information fueling registries that are in place, but it's often that there's not this real-time direct feedback loop to the patient at the point in time in care. We know and we want to provide information for machine learning. We know machine learning has the potential to continue this positive forward momentum, but it's hindered by limited non-standardized data. And a very specific issue in pediatric oncology is that because it's rare and individual cases are furthermore unique. Structured, standardized data lets us investigate more with what we already have and interrogating more on the image data than we already have available. This will make it possible and meaningful to use pooled data. Standardized reporting can facilitate interoperability with connected longitudinal imaging data that is built for purpose for machine learning. And then furthermore, ensuring that the information we report is accessible and it stays intact. It's not transferred to paper or entered manually. We assure this data liquidity in the format of the data. Leveraging other imaging evaluation tools such as volumetrics, radiomics, tumor growth kinetics will enrich this even more, as well as connecting this to clinical and mutational information for the full picture. But it also has to be easy and achievable, which requires the right investigative tool. And this as well is what's also going to facilitate this real-time means for case collaborations and second opinions. The overall benefit for this fueling of research with imaging data will lead to improved time to diagnosis and treatment for patients, improvements in observed outcomes for long-term survival, as well as understanding late effects of treatment, help us better understand in particular why treatments fail and when, enable this real-time feedback loop, not just data flowing away from the patient, but actually research opportunities with the possibility to real-time point-of-care feedback to the patient. And this can also provide a means to increase expertise development and training in the field of radiology at large. And this research, I believe, will further increase the impetus for funding in childhood cancers. And with that, I will thank you for your time today. Thank you for attending.